So I know that the beach and the golf course and lots of historic sites and things like that are awaiting you. So I'm going to follow on with some other interesting pictures. And hopefully there'll be a lot of participation and we'll get through these 4 cases fairly rapidly and have time for questions for those who want to stick around. As I mentioned this morning, one of my big mantras is that medicine is a team sport, and in prenatal diagnosis, which is a large part of my practice, that is no different. And in fact, I think the best outcomes and the best decision-making for the process include a multidisciplinary team. So I have no financial conflicts related to this presentation, but I do have one small disclosure. So when I was a resident, Joan was my second-year resident when I was a brand new intern, and she made sure that we knew we were to see all the patients and get the notes written before the attending showed up, because otherwise it would make her look bad. So, of course, I always followed her orders. So a month ago when I was turning in my PDFs of the PowerPoints and I heard that they were having active learning, it was something new they were going to try, I followed orders and I took out almost all the words on this one. So I'm going to do one thing that I just asked Joan if I could do. I'm going to take all my notes, put them by slide on a document, and give them to Lee to upload so that you have the notes to go along with the pictures. So that's my disclosure. I still follow Joan's orders. Okay, at the end of this session, we'll recognize hopefully the need for multidisciplinary approach to management of fetal malformations and explain how the prognosis for a fetal finding would inform the subsequent management and delivery of the pregnancy. And since most of my patients that we do prenatal diagnosis for go back to their OBGYNs or in some cases, in many cases, to their nurse midwives, especially if they're going to be delivering in our setting anyway for their OB care, I think it's important for everybody, not just the MFM, to know what goes into the diagnosis of these patients. And more importantly for the patient, I think, is the decision-making process for them. So we follow about a 6 or 7 step approach to diagnosis and counseling, beginning with prenatal presentation and diagnosis as a result oftentimes of abnormal screening tests, whether that be the first trimester screening test, the second trimester, a sequential, or the anatomy screen. Then, depending upon whether it's appropriate, genetic testing, get our genetic counselors involved. Talk about then whether this diagnosis is going to be lethal or treatable, and so that may include getting other pediatric subspecialties or surgical specialties involved. Other multidisciplinary team referrals. I don't want to minimize the importance of getting social work and pastoral care involved in the care of these patients. Very important to many of them in their decision-making process. Finally, determining if they're continuing the pregnancy, location, and mode of delivery. Sometimes also, in terms of other multidisciplinary referrals, if this is a lethal diagnosis or a diagnosis that the patient is not comfortable continuing the pregnancy, then if it's not something that you can provide for the patient, making sure they get referred to the appropriate family planning services. And then finally, when they're continuing the pregnancy, not just location and mode of delivery, but also talking a little bit so that they have the expectation of what the neonatal intervention prognosis will be. And coming full circle, you know, their question is, what did I do to cause this? And of course, we usually 99.9% of the time say, this is multifactorial, it's nothing that you did, but here's what you might be able to do to prevent it in the future. So this is sort of our process in working through prenatal diagnosis with the patient. So I'm going to use 4 examples here to give you an idea how this might work. So can we move the boxes back to the second row in each case there? So the more you speak up, the quicker we get to the beach. All right, so let me explain these pictures here to start with. Some of you may be familiar with what this is already, but I'll go through here. In the upper left corner, this is a cross-section or transverse section through the fetal cranium. You can see the falx with the medial and lateral wall of the distal ventricle. You can see the choroid plexus here, which normally fills up the ventricle, actually dangling towards the dependent side. Over here on the right, you can see a sagittal view of the lumbosacral area. This is more cephalad, this is more caudate of the spinal cord. Here you're seeing a coronal view of the sacral area of the spinal cord. Here is a transverse view of the sacral view of the spinal cord. You can see the iliacs here and the vertebral bodies here. And again, this is a transverse section through the cranium, but this time you're seeing the posterior fossa, and this banana-shaped structure here is the cerebellum. And while they're pointing out where the cisterna magna should be, you can't actually see it there because it's obliterated.
How many weeks is this?
Pardon me?
How many weeks is this?
This is about 20 to 22 weeks of pregnancy. Thank you for asking that question. So we'll start with your row there. What's this overriding fetal malformation here? And you don't have to be specific.
Looks like there's an abnormal ventricle.
And use the boxes in front of you, please.
Looks like there's an abnormal ventricle. Two sides are different.
Okay, there's an enlarged ventricle. What major malformation, we'll go over to this table here, is going to cause all of these findings that you see here? Right, an open neural tube defect. Good. And when would you, and please pass the box back to the next row rather than throwing it. The row behind you. And it can be to anybody in the row behind you. So, when are we most likely to find this malformation? What might prompt us to find this malformation? Let's start with this side of the room here in front of me. Okay, somebody said the quad screen. What about the quad screen? In what way?
AFP.
Elevated AFP, right. Or if a patient has declined antepartum screening, it might be picked up on the 20-week plus or minus a couple week anatomy screen, right? Okay, so this is just showing you for comparison normal views. So here is a cross-section through the fetal cranium. There's the falx. You can see the cavum septum pellucidum here. You can see a dumbbell-shaped cerebellum as opposed to the banana-shaped cerebellum that was being tethered down and obliterating the cisterna magna. You can actually see the cisterna magna here with spinal fluid in it. On this side, as opposed to the spinal dysrhythism that you saw here, where you can't actually see the median bony prominence there, you can actually see all three components of the vertebrae, the two lateral and the central component of the vertebrae. Here in transverse view of the sacral vertebrae, you can see all three, again, bony prominences pulled together into a nice tight circle or triangle, as you can over here as well with the iliac crests appropriately displayed. So, neural tube defects occur about 0.4 in 1,000 pregnancies, with the lumbosacral, as we're showing here, being the most common. And in this case, you had a myelomeningocele, so there were meningeal membranes as well as neural tissue in the defect and spinal dysrhythism, as we pointed out. Okay, you already told me what screening tests that you might see, so you wouldn't pick this up on the first trimester screen, but you would with the AFP on the second trimester screen, or on the ultrasound. What is our diagnostic test here? Where are how about over here on this side with the red box?
Well, you could, I would think this is it's pretty diagnostic just based on the ultrasound. I don't think you really need to tap her. But if you had a question of an elevated MSAFP, you could do an amniocentesis for an amniotic fluid AFP.
Right, and the amniocentesis might also tell us if there's a genetic association here as well. Now, the genetic association is only about 4% when you don't have other associated anomalies, with trisomy 18 being the most common, trisomy 13 the next most common, and triploidy the third most common, aneuploidy associated with open neural tube defects. However, if you find that you have additional anomalies as you do a thorough anatomy screen with the ultrasound, particularly things like cardiovascular, musculoskeletal, and renal anomalies, your incidence of aneuploidy goes up to as much as 40% association. So what are some of the risk factors? Let's go to this side where the red box is. Give me a couple of risk factors for open neural tube defects.
Less folic acid.
Okay. Less folic acid, so folic acid deficient or anything that disrupts folic acid metabolism. Anything else? Family history. Thank you. Okay, so there are some environmental causes. Patients on anti-epileptic drugs, some of them will disrupt folate metabolism and cause a functional deficiency of folate. Diabetes certainly does that. obesity, hyperthermia in the first trimester, especially during the critical period of formation and closure of the spinal cord, and amniotic band syndrome as well. Inadequate folate, again, there can be many reasons, not just anti-epileptic drugs for that. It can be dietary as well. You know, there are certain regions, typically before the advent of supplementing our breads and grains, there were certain regions of the world that were more folate deficient. Genetic factors, it's more common in monozygotic twins, first-degree relatives, and females more than male fetuses. And then associated with folate metabolism are some of the MHTFR polymorphisms that you may also be familiar with in thinking about coagulation defects. Okay, where's the red box on this side? Is this lethal or treatable, what we're seeing here in the pictures?
I don't work with neonatology. I'm sorry, I'm GYN.
Anybody else? Treatable, okay? Now that's not to say that along the line of treatment, whether it be antepartum treatment or neonatal treatment, that there aren't plenty of risk factors involved for infection and surgical morbidity and mortality that could make this lethal. So, most of you, I'm sure, are familiar with the MOMS trial, which was the management of myelomeningocele study. And that was performed at several centers that were doing the in utero fetal therapy, generally before 25. The cutoff right now is 24 and 6/7 weeks. And they have very strict criteria for eligibility in this trial, because the main thing was they wanted to determine if the outcomes were better for these children if they met certain criteria and could be repaired antepartum versus postpartum, where most of these cases, particularly with the severity that you're seeing in this picture, were already at 20 to 22 weeks the fetus has ventriculomegaly. Most of these fetuses, or neonates rather, were requiring VP shunts. So their eligibility criteria included lesions between T1 and S1 with hindbrain herniation. So they wanted to make sure that this was not a very mild case and they weren't doing this very morbid procedure for something that wasn't more urgent. And that had to be confirmed by sono and MRI in their center. This could not be, these could not be studies that were done elsewhere and sent with the patient. Again, below, I was right when I started out the first time, 25 and 6/7 weeks. See, now that it's nighttime for me, I'm glad I wrote down all these numbers. So, maternal age greater than or equal to 18 years of age, a singleton pregnancy, and they would have done an amniocentesis for a normal karyotype, so they would not have intervened for an aneuploidy fetus. Ineligibility included patients who the mothers had insulin-dependent diabetes. There were other fetal anomalies that were identified, so it had to be isolated neural tube defects. Fetal kyphosis greater than 30 degrees, because that's not something that they could correct, and that alone would likely impede the outcome, particularly if you're looking to improve ambulation in the child. Cerclage or history of insufficient cervix, because obviously you're doing a big hysterotomy and a laparotomy, and that already increases your risk for preterm delivery. Placenta previa or abruption, vaginal bleeding, shortened cervix, all of those obstetric problems would be contraindications. BMI greater than 40 for technical reasons. Prior spontaneous preterm birth, alloimmunization of any kind. Infections where doing this type of procedure would increase the risk of vertical transmission, uterine anomalies, and uncontrolled hypertension. So there was quite a long list of ineligibility. As with many of these trials for cutting-edge therapy for fetal anomalies, there are very strict criteria that patients have to meet to try to optimize the outcome when you're going through procedures that can otherwise be very morbid and risky for the mother and the fetus. So, what other members of the multidisciplinary team? Where's our box right now? Let's go to this side here. What other members of the multidisciplinary team, besides the obstetrician and besides the MFM, who might be evaluating this patient?
The neonatologist.
Absolutely, a neonatologist to give the patient an idea of what to expect at the time of birth, and perhaps talk a little bit about care after. Who else? Genetics, absolutely. Pardon me? Pediatric surgery, particularly pediatric neurosurgery. Who else?
Social work.
Social work, thank you. I think that we cannot underestimate, again, the power of having social work involved with these patients and also pastoral care. Now, going back to the ineligibility criteria, I didn't put this up here, but there are two other things. One has to do with social work. If social work in these centers that were involved in the study evaluated the patient and felt that there were other psychosocial barriers that would impede this patient from being able to tolerate what they were going to need to go through for antepartum therapy, and or it would be too much of a financial burden on the family. They weren't going to be able to stay there because they required that you stay there until the time of delivery. Or if the patient did not have a support person, it made them ineligible for these procedures. So again, that social work is extremely important. Okay, location and mode of delivery. So is this somebody that you would feel comfortable delivering in your community hospital, or is this somebody you'd want in a tertiary care center?
Tertiary.
Tertiary care center, right, because you want pediatric. Now, any of us can deliver this baby, but you want pediatric staff there that are going to be comfortable managing it in the immediate postpartum or neonatal period so that they can stabilize the patient, protect the defect, and bring neurosurgery in to take a look and determine when they're going to do the closure, and if that's even possible at the time. Oh, the other question up there was mode of delivery.
Cesarean.
I hear a lot of people saying C-section, but believe it or not, there are no randomized controlled trials. And for those of you that perform C-sections, you know that C-sections are not atraumatic. And so we're oftentimes still dragging the baby out of there, and if you've got a membrane covered, unless you're going to splay open the whole uterus, which we try not to do. If you've got a thin membrane covered defect, it may not be any more protective than doing a vaginal delivery. Again, a lot of it's going to make a big difference on whether or not, what is the head size, so we may deliver some of these patients a little early. If you've got a macrosomic fetus, meaning a really macrocephalic fetus rather, meaning a really big head because of expanding hydrocephaly, especially if it's over 42-week size already. If you have an encephalocele, there are some opinions, again, no randomized controlled trials, but opinions that may be better delivered by cesarean section. But otherwise, for the most part, if you have a normal head circumference, these babies can be delivered vaginally. What we do want to make sure we do, however, is that we have a sterile bag to slide the baby, the lower half of the baby into, to make sure that we protect that defect when we hand the baby off to the waiting pediatricians. I told Joan I was going to tell this story. So we always have the sterile bags. The pediatricians are always set up in the room, ready to go when we know we were doing these deliveries. In fact, I've done these deliveries, vaginal deliveries, with medical students when the residents were off at school before, and I'm standing there with the bag while the medical student does the delivery there and pull it up over, of course, right underneath the axilla. So I had this wonderful chief. We were in the OR and we knew this baby was going to be born with a big lumbosacral defect. He was very kind. He was very smart. His patients loved him. The nurses, everybody loved him too. So he lets his second-year resident, he was chief now, pull out the baby, deliver the baby from the uterus, and he takes the bag and he just pulls it up over in the entire baby. I'm like, wait a minute, didn't your mother teach you not to put plastic over your head? He was about to get married. I told him he was not ready to be a father yet. I didn't know whether to gasp or laugh at that point because I couldn't believe he did that, but he rectified that pretty quickly. So never assume anything, the bag up to the axilla. And you hand them off to the waiting pediatricians and then they'll dress it appropriately. So the question is always antepartum versus neonatal intervention. So it sounds cool that we can do this antepartum, but what evidence do we have that it actually improves the outcome? So that's what the MOM study set out to answer that question. And there are a couple of studies. One was published in 2011 and another in 2016. The 2011 was the initial evidence coming out from the MOM study that showed that the need for shunt with antepartum repair, so closure of the defect, showed a decreased need for shunt placement in the first year of life. So almost by half, so that's pretty good compared to neonatal closure of the defect. The neonatal closure, on the other hand, showed less preterm delivery. Well, that makes sense. You're putting a big hysterotomy in the uterus, and mother's obviously going to be at risk for preterm delivery then. Although, from a standpoint of respiratory maturity, 34 weeks versus 37 weeks isn't terrible, given that we don't even give steroids after 34 weeks for the most part. Now, I know there's some studies out there that are looking at potentially doing that a little bit later. The other thing antepartum surgery did for us, for these babies, and again, these are the babies that met the criteria that we talked about, was that it improved the composite score for mental development and motor function at 30 months. And interestingly, looking at the longer term data that just came out in February of this year, it shows that there may be some improvement in long-term ambulation as well, but not so much improvement in incontinence. So that seems to be a hurdle that we still have. And for those that had normal head circumference that were antepartum repaired and had normal head circumference at birth and normal neurologic development, they also have to seem to have better development of your daily living activities and less executive functioning disorder than the neonatal patients, neonatal repaired patients did. The neonatal repaired patients clearly had fewer pulmonary complications. Again, more of them were delivered at term than preterm. There was no difference in maternal complications, or there were fewer, maternal complications with the neonatal delivery, so less abruption. Obviously, they didn't have a big hysterotomy, no dehiscence, and less need for transfusion, but there was similar fetal and infant mortality in the long run. And I think it's important for us to, let parents know that in terms of morbidity and mortality, because of the need for surgery and because of the extensive hydrocephalus and need for shunting that can occur over time, that the 20-year survival rate for these babies is really about 50%. Other things that they should know, if you look at the gold standard of neonatal repair, is that about 35% of those that are live born will die at less than 5 years old, depending upon the level and the severity of the defect. About 50% will have IQs greater than 80. So I like to look at the glass half full, but you know what the other half of that is. About 25% will have lower extremity dysfunction, and that really is going to depend on where the level of the lesion is. So if you have a sacral lesion, those like S2 to S4, those children are likely to be able to they'll frequently be able to develop walking normally without aids. But as you go up to T1, those are the children, as you go progressively higher, that are going to need braces, either half-leg braces, full-leg braces, or be wheelchair bound, except maybe for exercise for the majority of their life. So I think those are all things for parents to take into consideration that they need to hear based upon our best ability to tell them where this lesion is in the antepartum when they're making these choices. So long-term prognosis, I talked about there a little bit, and prevention, well, I think we all know what that is. So the general prevention for the public that doesn't have any risk factors is 400 micrograms of folate daily, and periconceptionally, and through at least the first trimester of pregnancy. And for those that have had an infant with a neural tube defect or have some of the other risk factors we talked about, it's 4 milligrams, right? Very good. All right, on to the next one. Let's take a look at this here. So this is our second example. This is a cross-section through the chest. This is the posterior. You see the vertebrae, anterior, left side, right side. So already you know situs is correct. This is the heart and the lungs here, so it's a cross-section, again, through the thorax. The apex, the atrium, the ventricles, the ventricular septum, atrial, and these are the mitral and tricuspid valve area here. If you look at it a little bit bigger here in another orientation, again, you can see the ventricular septum, the two ventricles, the valvular area, and you can see the foramen ovale, just very lightly, this little membrane here, a little space here. And this is a little bit later on in pregnancy. And here you see, in addition to what I already pointed out, some pleural effusion. So who has, you can pass the box forward and backward there. How about the very far back there? Any idea of what this malformation is? That was nice. I saw you pass that off. Anybody else? Go ahead and just shout it out if you know what it is. There is a valvular problem, right? There's a VSD, there's an ASD, and there's essentially a univalve here, because you can see instead of the valves being offset, which I'll show you the normal in a minute, it looks like they go straight across here. So this is an AV canal malformation. When would we most likely pick this up? On ultrasound, at that 20-week ultrasound, if you can't get normal 4-chamber views, for example, especially if you pick up on the fact that you have the valves going straight across as opposed to being attached kind of offset on the ventricular septum, or you can see the septal defects above and below that area as well. So here again, you have an ASD in the AV valve, AV canal malformation. You have a VSD, an atrial and a septal defect. You have a single AV valve, atrioventricular valve, and you have an increase in left to right shunting. This type of defect occurs about 0.2 per 1,000 live births. And this is the normal view here. So you can see here is a complete septum. Here you can see the atrial septum just above the crux of the mitral and tricuspid valves. You can see that the valves are a little offset where they're attached to the septum here. And again, you can see the foramen ovale. So this appearance of a defect is normal because you can see the more thin-walled foramen ovale bulging off to the side here. So no septal defects and appropriately placed valves in this case.
Do you think you would pick that up in the fetal heart test before the scan?
No. Usually they're going to have normal rhythms. You wouldn't necessarily pick that up. Good question. The question was whether or not you'd pick that up by fetal heart tones or the Dopp tones.
If she had a nuclear translucency, that would probably be abnormal.
So that's another time, exactly. So not always, but when you have an abnormal nuchal translucency on the first trimester screen, and if, say, you follow that up and maybe you did a CVS and there were normal chromosomes, it's still indicated to look in the third trimester, or even if you can get an earlier echo. There are some centers that are offering earlier echoes, especially using transvaginal, but still the gold standard, especially if you talk to the pediatric cardiologist, so here's some of your multidisciplinary referrals here, they prefer to take a look at these between 20 and 24 weeks of pregnancy when the heart's a little bit bigger, to be more sure of the diagnosis and the extent of the defects. But as you said, if you have an increased nuchal translucency and you've done your CVS, there's no evidence of aneuploidy, maybe you've even done an array to look for gene defects, and all of that seems to be normal, there's still an indication with an isolated nuchal translucency to look for cardiac defects in the mid-trimester and also for skeletal dysplasias. Thank you for bringing that up. So, aside from some of these screening tests that might reveal this, what are some other high-risk conditions for which we might routinely request that our patients get a fetal echocardiogram along with or subsequent to their mid-trimester anatomy screen? Prior history of cardiac malformation, particularly in a first-degree relative. It's a lower risk in a second-degree relative. What else? Diabetes, absolutely, is an increased risk of cardiac malformations. One or two others? Anybody think of any others? I'll give them to you. Okay, so diabetes you mentioned, phenylketonuria disease, patients who have SSA or SSB positive antibodies. These are often your patients with connective tissue disorders, more likely associated with fetal heart block. But we usually do the echo so that we can look at rhythm as well as look at structure in this case. Patients who have had early known exposure to CMV, adenovirus, Coxsackie virus, cardiac teratogen medications, first-degree relatives, as we mentioned, and we're finding an increased incidence in patients who had assisted reproductive technology too. So we are routinely in our center offering now fetal echocardiograms to those patients. Not necessarily with Clomid or Pergonal, but with other forms of assisted reproductive technology. Fetal indications, you suspect an abnormality because on dop tone you hear a dysrhythmia. So a dysrhythmia may more likely be associated with a cardiac malformation, but the cardiac malformation doesn't always go hand in hand with the dysrhythmia. So that gets back to your question. Other non-cardiac abnormalities, particularly what kinds of non-cardiac abnormalities would we look for? We talked about one already. Other midline defects, like neural tube defects, we would look for cardiac malformations. Abdominal wall defects, we would look for that. Two-vessel cord is a little bit lesser indication. It's not a high risk, it's a low risk indication that you might consider getting an echo as well. And when I say high risk and low risk, I'm talking about these are associated with a greater than 2% chance, a 2% or slightly greater chance, depending upon the condition, of being associated or causing or association with a cardiac abnormality versus a 1 to 2% chance. That's why we say lower risk. I know for the parent that's not a low risk at all. And then some of the other things are listed up there as well. Genetic association. If I tell you your patient's fetus has an AV malformation and I say we did some genetic testing and it came back positive, what is the most likely problem genetically that this patient has? 40% of the time, this cardiac malformation is associated with this genetic abnormality. Down syndrome, right. So it's almost as if this is Down syndrome until proven otherwise. And I think that's an important thing to tell the patients, that that association is that high. Other associations, 20% of the time it can be trisomy 18 or trisomy 13, and part of that is because trisomy 13 and 18, as opposed to other aneuploidies, have a higher chance of still being viable at the time you're doing these anatomy screens. And the other thing is to do testing. If those are all normal, do testing for DeGeorge, which is the deletion on chromosome 22 at position Q11.2. So that's another common genetic malformation, but a single gene defect. So lethal or treatable? Particularly if it's not associated with any chromosome problem, it's certainly treatable. That does not mean, just like with the neural tube defects, this is a staged procedure in repairing this after delivery. And so with each one of those, there's a 5% chance of mortality with each of those surgeries. So lethal may be a very strong word, but the mortality can still be very, very high here. Other members of the multidisciplinary team. So we already mentioned either radiology or OB would have done the ultrasound, or perhaps MFM would have done the ultrasound or been consulted if there was concern or an abnormal screening test early on. We talked about peds cardiology. Who else are we going to get involved here? Okay, a pediatric cardiac surgeon, absolutely, in pediatric cardiology. Also, who else? We talked about genetics already. Social work and potentially pastoral care as well. So for both of these malformations we've just talked about, one of the things we would be offering this patient is whether or not they would want to consider termination of pregnancy, and that we would be supportive in either case in helping them plan for the rest of their pregnancy. Location of delivery. Again, tertiary care center or community hospital, or either?
Tertiary care.
So in this case, it would be a tertiary care center. And I'll show you a table here in just a minute that looks at ductal-dependent lesions versus non-ductal-dependent lesions. And some of these actually can be delivered in a community center as long as pediatrics is present to be able to take a look at the baby within a short time after delivery. In this case, however, this is something you'd want to deliver at a tertiary care center. And the way we do it in Maryland, too, is right now we are getting all of these patients referred to us at Hopkins. When University of Maryland, just for Maryland, when University of Maryland has a pediatric cardiac surgeon, they're just in between at the moment, they will also accept these patients. So it's really important that it's not just any tertiary care center, although any tertiary care center could certainly stabilize the baby as well. But for both logistics reasons and I think also for the mother to be able to be there with the baby, it's best if you can deliver the baby where the baby's going to be taken care of, particularly if anything needs to be done more urgent. Mode of delivery, vaginal, C-section, or either? Vaginal delivery, right, unless there's any other obstetric complications. Thank you. All right, so this is that diagram I was talking about, or the table I was talking about here that breaks it up into, in the upper left-hand corner, these are the ones you most definitely want in a specialized delivery room in a tertiary care center where you have neonatology and pediatric cardiology involved. These are the patients that have, for example, transposition of the great arteries or sustained or uncontrolled tachyarrhythmias with or without any other malformation or with or without any other cardiac malformation. The next step where it may be considered, and I would venture to say all of us would probably want this anyway, to have at a tertiary care center with PEDS cards, is tetralogy of flow with absent pulmonary valve, Epstein's anomaly, particularly in the face of high drops, and total anomalous pulmonary venous return. So again, you're looking here at the ductal independent lesions versus the ductal dependent lesions that can often be temporized with Indocin. And as you travel to the bottom left here, it may be reasonable for hypoplastic left heart. I can tell you most community hospitals, if they know a baby's going to have a hypoplastic left heart, no matter what you tell them about their capability, they're probably not going to want to deliver this baby there. So typically we'll get all of these patients, including those with complete heart block. The ones with complete heart block are really pretty tricky to monitor in labor too, so you need to know for a prolonged period of time before labor potentially where that baseline is. And then finally, mild TET, shunt lesions, most ductal dependent, could actually be delivered with a pediatrician in attendance, but not necessarily in a tertiary care facility. All right, neonatal intervention. I talked about very briefly already that this is a staged repair that usually occurs at about 4 to 6 months post or neonatal, or post-delivery rather. These babies can often tolerate an oxygen saturation in the 80s, so you want pediatricians that are comfortable with managing babies that are going to be maintaining their O2 sats in the 80s because they have a lot of mixing of their blood. They will be symptomatic, however, and the parents have to be instructed in what level of fatigue is baseline, so these babies will have a little longer hospitalizations to figure those things out. They may have trouble breathing and eating. Again, it's important to know what the baseline so parents can detect changes when they go home with the baby. Poor weight gain and growth, obviously follow both of those. And increased sweating. So these babies will be maintained on ACE inhibitors or digoxin to support the heart until which time it's deemed appropriate to begin the staged repair. And that repair you can see here because they have to fix the ventricular septal defect, they have to patch the ASD, and they have to rebuild the mitral and the tricuspid valves as well so that it's not a univalve. And again, each of those stages may have up to a 5% operative mortality, maybe more depending on if there's other comorbidities for the infant. And there's about a 70% 20-year survival rate with these fetuses, or with these infants rather. So prognosis, I alluded to that. The other thing is once the repair, if it's successful and they have normal oxygen saturations, they may go on to have a very active life, but again, they're taught to, 1, have endocarditis prophylaxis when they have procedures done, and 2, to avoid contact sports. Okay, the third one is another organ system, which you probably figured out already by looking at this. On the bottom left here, we have a cross-section through the abdomen. You can see this is the anterior, this is the posterior of the cross-section of the abdomen. You can see the umbilical cord coming in, and you can see a mass outside the fetal abdomen here. This is the placenta up here. In this picture here, you have the placenta a little bit further along. You see, again, a transverse view of the abdominal circumference, and you see loops of organs out here in the amniotic fluid. And over on this side, you see a cross-section in the lower part of the abdomen where you see both the stomach inferiorly displaced right next to the bladder here. What is this fetal malformation? Why do you think it's omphalocele? Okay, so you do see loops of bowel. That is absolutely correct. Is there a membrane that you can identify around all of these? Gastroschisis, absolutely correct. But this is a tough thing sometimes to identify unless you get the right views, because you could have a ruptured omphalocele. Remember, the omphalocele has the membrane covering it. The gastroschisis has a paramedian defect with the bowel coming out next to the umbilical cord, usually to the right of the umbilical cord. And here you're seeing tethering down because as the bowel contents are extruded, it's pulling down on the stomach as the intestines are extruded there. And here, you don't actually see a membrane all the way around. And usually it's in a little bit better bundled pack there when you have an omphalocele. When would you most likely see this? Or identify this? Pardon me? When would you most likely identify this malformation? Anatomy screen, right. The other thing is you could have an elevated AFP on your quad screen or your second trimester screen as well with an abdominal wall defect, either the omphalocele or the gastroschisis here. This is usually, let me show you the normal view here. Oh, that's the abnormal one. So, this is what I wanted to show you there. I put this picture in so you could differentiate a little bit better between the gastroschisis, where there's no membrane and it's a paramedian defect, versus the omphalocele, where you can see the membrane encompassing the mass that's extruded from the fetal abdomen, and you see the cord inserted distally as opposed to next to the defect there. So that's how you tell the difference between the two. And the gastroschisis is usually a defect in the infolding of the abdominal wall in embryologic development, and some think that there might be a vascular accident in the mesenteric vessels that cause this to happen and to not completely close with the gastroschisis. Which one of these is more likely to be associated with the genetic abnormality? Omphalocele, absolutely. Oh, this is the normal view for you here too. So here's your cross section, and here's your normal cord insertion at the level of the umbilicus, where you can see skin coming up on both sides and the 3-vessel cord here. Okay, so with gastroschisis, if there is a chromosomal abnormality, it's very sporadic. But it does, however, occur about 4% in siblings. Omphalocele, on the other hand, trisomy 18 is the most common aneuploidy that you might see with the omphalocele. It's more commonly associated with chromosome or genetic defects. Trisomy 21 is the second most common, and Meckel-Gruber syndrome, the third most common genetic condition associated with omphalocele. So again, some differences in genetic association. Thinking of gastroschisis, or omphalocele for that matter, lethal or treatable? Treatable, particularly when there's no other associated malformations, which is most often the case. It's an isolated defect for gastroschisis. Other members of the multidisciplinary team. Pediatric surgeons, right? That's probably one of your biggest. And then, of course, your neonatologists, so that they're there to help care for the baby and stabilize the baby before they start addressing the defect. Again, you may get genetics involved, because in the off chance that you couldn't get a good view of the cord insertion, you weren't sure if it was distally inserted, or now you had a ruptured omphalocele and now it looked like it was laterally, you weren't sure, you might still consider getting a genetic consultation here. But most of the time it's fairly easy in a center that does this type of diagnosis to discern between the two. Oops, did I miss something? Oh, we talked about that. So location and mode of delivery. Location first. So tertiary care center is a good idea because they generally begin this repair almost immediately after delivery, after the baby's stabilized from a respiratory and cardiac standpoint. Mode of delivery. C-section, vaginal delivery, or either? Right, so with the gastroschisis, even the smaller omphaloceles, but gastroschisis in particular, usually a vaginal delivery is absolutely fine. So there are no randomized controlled trials looking at this, nor are there randomized controlled trials looking at timing of delivery for gastroschisis. There is a study that is in development right now that's looking at timing of delivery. But right now, in terms of location, again, tertiary care center, mode of delivery, unless liver is out, and this is very controversial, unless liver is out, they're usually candidates for a vaginal delivery, again with the plastic bag as soon as they come out to cover the bowel and then hand it off the baby to the pediatrician so that they can take care of it sterilely. There is some controversy if the liver is extruded. Many people will opt at that point in time for a cesarean section. But again, when you look at the side-by-side cohorts, there's no difference in morbidity and mortality for those that either on purpose or mistakenly with the liver out were delivered vaginally versus those that were delivered by cesarean section. Because again, as I pointed out earlier, a C-section is not atraumatic. We have to really jostle those babies around, still pull them out of those hysterotomies sometimes. Neonatal intervention includes the silo approach. So keep in mind that most of these babies are functionally IUGR because when you're looking at the estimated fetal weight on ultrasound, that abdominal circumference plays a big part. If most of your abdominal contents are outside, that abdominal circumference is going to be very small. And so these babies' estimated fetal weights are going to be much smaller. When it comes time to place the bowel back in, we don't push it all back in because as you can see on this little baby, that abdomen's so small, there would not be good circulation if we tried to stuff all that bowel in back at once. So it has to be a gradual process using the silo, which is what they'll do in the NICU, and the pediatric surgeons will come in, evaluate the bowel every day for circulation, make sure nothing looks necrotic, and a little bit at a time, almost like a tube of toothpaste, roll it down and push a little bit more back in as the abdomen distends more before they actually do the closure. Depending on the size, it could take a couple days, it could take a few weeks for them to be able to do the closure here. All the time watching very closely for any evidence of necrosis and monitoring perfusion. Parenteral nutrition this is showing you the stage closure here. This took place over about 3 weeks actually, because you can see how big that defect was and how much of the bowel was out at the time of delivery. These babies oftentimes, even once everything's back in, will need parenteral nutrition for a while until the intestines start to move everything along and they have good bowel sounds. Oh, prognosis. Let me go back to this quickly. So prognosis for these babies really depends upon bowel complications, both antenatally and also in the neonatal period. Because more so even than omphaloceal, gastroschisis babies are at risk for bowel obstruction, for atresias developing, and for ischemic effects on the bowel. There is a 90% survival rate, however, but 10 to 15% of these babies can be left with dysmotility issues. If you look at a comparison of the prognosis between gastroschisis and omphaloceal, obviously the big thing is going to depend whether or not there's associated aneuploidy here. There's a lower incidence of anomalies with gastroschisis, lower incidence, as we said, genetic association. Liver herniation is uncommon, more common along with lung hypoplasia in the omphaloceal, which is why they also have a slightly less favorable prognosis for survival. But there is a higher degree of potential intestinal damage. If it's a very large omphaloceal, there can also be cord accidents, and so there's a higher rate of fetal death or in utero fetal demise. All of these babies are at increased risk in the course of the repair and following of having long-term GE reflux, of having feeding difficulties, and bowel obstructions in the process. Okay, our last one for the day. And then it's beach, golf time, whatever your favorite flavor is for the afternoon, maybe even a nap. How about this fetal malformation? Let me give you some orientation here. So maternal anterior, posterior. Here's the placenta. Here's the profile of the fetus and the cranium. The spine, you can see a little bit of it down here. You can see a femur, because the legs are coming up this way, here. And that's about all you can see there. Over on this side, there's been an amnio infusion done. So here's a cross section of the upper part of the abdomen, just below the stomach. You can see the fetal adrenal glands with a very anterior, they look flattened and they have a very anterior to posterior orientation as opposed to their usual oblique orientation. This is a coronal view of the aorta. Question mark that we may be missing something here. What do we have here? Potter syndrome, but why? I thought I heard somebody say something. Renal agenesis, bilateral renal agenesis. So you also have anhydramnios here. When are you most likely to pick up on this? Are we going to see this on our dating sono in the first trimester? Closer to 20 weeks, right, because less than 16, 17 weeks of gestation, there is very little fetal renal contribution to the amniotic fluid. The amniotic fluid by about 22 weeks is really more, almost 100% fetal renal, or fetal urine rather, at that point in time. So early on, you're not going to be able to pick this up. You may also have an elevated AFP, by the way, if you're doing it at 17 to 20 weeks of pregnancy. All right, these are normal views. So normally we're going to see plenty of amniotic fluid in the sac. You're going to be able to see the profile outlined nicely, not flattened. You'll be able to make out the limbs. Here's a hand. You'll be able to see the ribs and the spine and the heart. Because you noticed in those other pictures, you actually couldn't make out the anatomy very well because you don't have that fluid interface, which is important to get a detailed high-resolution ultrasound. Here you also see the kidneys, and you don't see the adrenal glands. If you did go a little bit higher on this, you'd see them a little bit more oblique as opposed to anterior, posteriorly directed and flattened as we did in the renal agenesis. And on the coronal view of the aorta, you can see the renal arteries as well. So going back to this, what are the risk factors for fetal renal agenesis? Potentially very uncontrolled chronic hypertension. Even more so than that. We already said this was a risk factor for two of our other anomalies today. Not quite so much unless there's other associated abnormalities. Aneuploidy if there's other associated abnormalities, which at this point in time, without doing the amnio infusion as we did on the right, you wouldn't be able to see that. Maternal diabetes, absolutely. Keep in mind that uncontrolled maternal diabetes and the embryologic development increases your risk of neural tube defects, of cardiac defects, and also of renal agenesis. So you may also see, if you find other anomalies once you've done your amnio infusion, VOCTERAL association, if you remember that from way back in your pathology there. Vertebral stands for vertebral anomalies, and maybe I actually have that up on here. Oops, I thought I did. Vertebral anomalies, it stands for cardiac anomalies, TE fistula, renal anomalies, and limb anomalies. Again, primarily due to the fact that without any fluid, you're going to get contractures, flattening of the facies, so the Potter sequence that you mentioned as well. Lethal or, whoops, oh, there they are. There's all your genetic associations. Lethal or treatable?
Lethal.
Lethal. Gold standard is absolutely lethal, and this is one of the most devastating things you can reveal to your patients. Even so, sometimes they don't want to believe you, because who wants to believe this about your child? So who might be helpful in explaining this condition, the prognosis for this fetus to the patient? Potentially genetic counselors, even more so. What do you expect if this baby goes to term and is born? What do you expect at the time of delivery? Right, and why doesn't this baby survive? Lung hypoplasia, absolutely. It's very, very important that there be normal, or at least, we don't know exactly what the threshold of normal is, but sufficient, however that's defined, amniotic fluid, particularly in that 7 to 22, 24 or so weeks when the cannulization is occurring in the lungs. Very, very important to have that amniotic fluid present. And without that, you get severe lung hypoplasia. And oftentimes when you do the amnio infusion, you can see that the chest is much smaller than it should be, and you kind of get that bell-shaped belly sticking out if you look at the sagittal views there. So very definitely, I'll tell you a story in a minute about what might bring that into question at some point in time. But right now, this is considered by gold standard a lethal anomaly. Other members of the team obviously would be pastoral care, social work, and neonatology, or the pediatricians, because oftentimes they will hear it from you but not fully understand it until the pediatrician or the neonatologist starts talking about why they can't resuscitate their baby at the time of birth. And you would want to have the discussion certainly about termination of pregnancy, and the majority of families do choose termination of pregnancy in these cases. Some, even so, will take this a step further, especially if they're not inclined to terminate the pregnancy for personal or religious reasons, and they may want to seek a pediatric nephrologist or kidney specialist to talk about this. Is there anything that they can do? And I will tell you, even then, they will tell them that if with no amniotic fluid, this is going to be a lethal condition. Location for delivery. Pardon me? Absolutely. I would highly recommend that this patient deliver where she came from, among her family, her obstetrician gynecologist, or nurse midwife, or nurse practitioner that she's come to know, and with family and friends surrounding, because this is exceedingly emotional if she's going to continue this pregnancy. And also, I hate to say this, but it's less likely someone would get zealous and try to resuscitate this baby in a community hospital, because they wouldn't necessarily have the equipment for a small baby and the oscillating ventilators and that sort of thing. Mode of delivery. Vaginal. Fetal monitoring in labor. No. Good. So the prognosis is very poor, obviously, is lethal, and we recommend no neonatal intervention except care and comfort only. Now let me tell you a story that might bring this into question. And this is anecdotal evidence, so let me put that disclosure out there right now. So about 7-8 years ago, I guess it's 8-9 years ago now, we had a patient who came to us who had anhydramnios. Did not appear that she was ruptured. We did a blue dye test that was negative. Everything else about the fetus was normal, and in fact there were kidneys there. And so we offered her in our institution, this was about 20 weeks of pregnancy, serial amnio infusions, because this otherwise, and genetics were normal too, this otherwise seemed to be a baby who was fine, and she did not want to terminate the pregnancy. This baby was born at 32 weeks of pregnancy, needed a little nasal cannula, a little PPV to start with, but otherwise had normal lung volumes, did well, did not need any respiratory support to speak of, certainly not any ventilatory support. This child's about 8 or 9 years old right now, developing normally, doing well in school. Fast forward about 5 years, and this family happens to know this couple who were diagnosed out in Washington State with renal agenesis. This was a deeply religious couple, and that doesn't mean that religious people don't terminate their pregnancies, but in their religious mindset, they were not going to terminate this pregnancy. And so they knew this other couple, and they knew what had happened here. And they thought, well, gosh, I wonder if there's something. Very educated couple. They went and talked all on their own to nephrologists who clearly laid out that even if there was amniotic fluid there, we could put that back. This baby would be on peritoneal dialysis and may or may not be able to get a kidney transplant, because they were asking all of these questions, thinking into the future, into the unknown. So because we did this for these other acquaintances, they came to us, and also because she happened to work. If you all have seen this case in People magazine, if anybody reads People magazine, this is a congresswoman from Washington State. She came to us and said, I'm not terminating the pregnancy. We want very much to try, and they had named their baby and everything, to have a live-born child, and even so that she can just be baptized afterwards. Went into the whole thing. It was very convincing to one of my partners, and then to me. And so we actually did, starting at 22 weeks, weekly to every other week, and eventually became weekly, amnio infusions. Knowing, and she knew full well, one, this is painful every time, there's a risk of choreo, there's a risk of ruptured membranes, there's a risk of preterm delivery, the whole kit and caboodle. She knew everything. She was very well counseled by the nephrologist, by the transplant surgeons, by the neonatologist, everything, that this may not work. So of course she was out seeing her constituents at 29 weeks of pregnancy in Washington State after about the 5th or 6th amnio infusion. doing her, going about her business, doing her job, and she ruptured membranes out there and went on to deliver the baby. They were very uncomfortable with this at the hospital that she was at, but Stanford said, send us the baby. So the baby had a very long hospitalization, obviously, had peritoneal dialysis. She turned 2.5 this spring and had her transplant with her father's kidney that was almost a perfect match for her and all the HLA antigens and everything. She had to be fed by an NG tube almost her entire life because she had really no appetite to speak of, as most people do that have chronic renal failure. And so she had poor weight gain, but better with the NG tube, but on her own had poor weight gain. She was otherwise meeting at 9 months of age when we did publish this article in the Green Journal about this one case study. We took a lot of heat for this, let me tell you, for even trying this. Interestingly, even from some of the people who questioned it at the MFM, we see on some of their websites they talk about this as a trial that they're thinking of starting. So, right now this is a highly expensive, highly painful, high morbidity and mortality risk for mother and the baby. It may be that there will be technologies in the future, 5, 10, 15 years from now, that will make this more routine. But this is still very anecdotal evidence, very anecdotal evidence. We have done one other one since then, and that baby is, when I say doing well, it's all relative when you're getting continuous peritoneal dialysis and NG tube feedings as well. And it all relies on finding the right donor. And again, anybody with a kidney transplant, there's the risk of this happening over and over again. So this is by no means standard of care. But one of the things we like to do when we give these talks is to tell you with each of these what some of the cutting edge or trials are that might be going on. So again, in this case, it was very multidisciplinary in order for this child to get this far, and particularly after delivery, certainly out of the hands of the obstetricians at that standpoint. So for all of these 4 cases that we talked about here, or anomalies, hopefully you can see how we utilize each of these steps to try to give the parents the best knowledge in helping them to make decisions about what the current prognosis and the long-term prognosis would be for their fetuses, and to determine if there are any other comorbidities or genetic factors that might be involved.
I just had a question about that last case. When she was that baby was never at Hopkins, right? Just at Stanford.
Yes. The idea was she was going to deliver here because mom was stationed, if you will, in D.C.
Right.
But that didn't happen.
Well, but when all was said and done, when it got to the point of, resuscitating the baby and all that sort of thing, that was great, and the baby was going on and on. I'm sure Stanford brought in the ethics department to get involved with this whole thing. In other words, what was Stanford standing? In other words, we can do a lot of things now. This has been showing up in situations where we've had our young men and women injured in battle. And I mean, remember, they're doing their surgeries now are in sections. They do a little bit, and they'll do a little bit more, a little more. So we can save people. We can make them live.
Right.
And what's difficult for the parents in a situation like this is, here's a child who's got a tube in, and all these different things. I mean, when this happens to an elderly person, your mother, your father, your aunt, your uncle, your sister, you have a hard time with that, even after they've lived for 50 or 60 years. And here you brought a child into the world, and you're going to be here for a while, but what's going to happen to this kid? I mean, it's a tremendously difficult.
So when the baby
answers.
was delivered in Washington State, they obviously had a lot of difficulty with this, even though they were. In fact, the maternal fetal medicine physician that was involved was one of our former fellows out there, because she had originally diagnosed this patient with renal agenesis at that time. And they had all these discussions and the ethical considerations, financial, social, and all the resources that would have to be put into play for something like this. When the baby was born out there, it needed very little, at 29.5 weeks, she needed very little respiratory support. So at that point, and they had normal lung volumes. So at that point now, you had a fetus with normal lung volumes that could breathe, and a neonate. And so that sort of ethical thing was out of their hands
Yeah.
at that point. The heart was fine, the lungs were fine, she was ventilating fine, but they were not comfortable with doing the intraperitoneal dialysis. So the baby was sent to Stanford. It is not my understanding that ethics got involved there because, again, they received a baby with normal functioning heart, normal functioning lungs at that point in time. So then it would be almost like you had somebody with severe oligo for another reason or renal failure for another reason that you didn't know about ahead of time and was delivered. I totally agree with you that there are a lot of ethical and resource questions brought to bear on this case.
Would that have been offered to just anybody, or was it just because of who she was, that she got that kind of treatment?
So it was not offered initially. It was requested, and then there was a large multidisciplinary committee that got together, including our ethics people, and talked about it as well. And yes, they had a lot of co-pays as well. Interestingly, their insurance covered a good bit of this. Interestingly. Pardon me? She had a vaginal delivery. Thank you. She had a vaginal delivery.
Any of these babies with the agenesis that are lethal anomalies, do they have transplantable organs that can be used?
So that's another thing that comes up. So typically, got it. So for those of you that feel like you want to get up and go to the beach, I'm happy to stick around and answer other questions. Otherwise, we're done, but I will answer some of these questions still. I'm happy to. Oh, sorry. I thought you were telling me I had to wrap it up and finish. I misread her signs after all of these years. So getting back, the question that was asked was, do any of these babies have transplantable organs? Again, it depends on how far along they get in gestation. Typically, if they're considering termination at 20 to 24 weeks, the answer to that is no, not yet. But there are a lot of things being done with fetal tissue and that may be on the horizon, that may be able to, instead of using pig tissue, for example, that we do for regeneration of human tissue or replacement of human tissue. So who knows down the line. But unless they're closer to term, the answer is no. Thank you very much. Thanks for getting up early, and thanks for sticking it out till the end.